session. Next, I'll call upon Dr. Nia Joy. She is working as a medical retina consultant in Aster MedCity. She is talking on regarding ocular complications of anti-VEGF agents.
Good afternoon all. Today I will be talking on intraocular complications of anti-VEGF injections. Before going to the topic, just a brief of what all are the indications for anti-VEGF. It includes age-related macular degeneration, diabetic retinopathy, retinal vascular occlusions, retinopathy of prematurity, neovascular glaucoma, as well as intraocular tumors. Which all are the anti-VEGF agents which we are commonly using include bevacizumab, ranibizumab, aflibercept, pegabtanib, faricimab, brolucizumab. Adverse effects are usually maybe it's seen after any intravitreal anti-VEGF injection, and it is not affected by any of the underlying disease. The endophthalmitis is the most devastating complication related to the intravitreal anti-VEGF. The rate of endophthalmitis is common in every set of diseases, every same geographical condition, same set of sterile theaters and all. Most important factor which is deciding the cause for endophthalmitis is the poor aseptic techniques which we are doing in the theater. And active external infection is the other factor which has to be ruled out before posting any patient for injection. Eyelid abnormalities such as ectropion, entropion, etc. also should be properly dealt before posting for an injection. What all are the precautions we should take in the theater before doing intravitreal anti-VEGF injection? 5% povidone iodine with 2 minutes contact time is definitely needed before doing an intravitreal anti-VEGF injection. Topical antibiotics can be started before injection. Use of a sterile lead speculum so as to avoid the injection syringe or lead butts or everything touching the surrounding area. Use of sterile gloves is also needed. And use of face masks is definitely indicated while doing an injection because of the spread of the respiratory infection. And you should avoid talking while doing the injection. And use of post-operative antibiotics, though controversial, we are giving in every cases so as to avoid infection. Intraocular inflammation is one of the main ocular adverse events related to intravitreal anti-VEGF. In large clinical trials of intravitreal injection of ranibizumab for AMD, the rates of significant ocular inflammation is less, that is less than 3%. And bevacizumab injection, it is even less than 1% or less than 0.5%. Severe ocular inflammatory events were reported, though the occurrence is less. And it is difficult to differentiate sterile intraocular inflammation from infectious endophthalmitis. How we can differentiate is usually in endophthalmitis, the symptoms may develop 1 to 6 days after the endophthalmitis, after the injection, whereas in intraocular inflammation group, it is that more early, in less than 1 day time. Endophthalmitis symptoms may be more severe than in acute intraocular inflammation, and you should consider every intraocular inflammation as or uveitis as suspected endophthalmitis, and we should follow up the patient like that only. And if needed, we should administer intravitreal antibiotics. RRD is one another complication related to intravitreal anti-VEGF. It has occurrence is less than 1%. Induction of PVD or due to an incorrect technique of injection is the main cause for the same. So how we can deal with this correct location, that is 3 to 4 mm posterior to the limbus according to the phakic status of the lens. Use small gauge needles and tunneled insertion of the needle to be done, because while pulling back, the vitreous shouldn't come back along while we are pulling back the needle. IOP elevation. Acute rise of IOP is common with every intravitreal injection. It is maybe procedure related, but the pre-existing glaucoma patients have a higher rate of IOP elevation. It may be sometimes associated with the pharmacologic effect of the VEGF blockade, or may be due to the inflammatory mechanism or trabeculitis. Refractory IOP rise, which is the patient is having a IOP which is not responding to the treatment, or it is not coming down, then we should start topical anti-glaucoma medication. It may be due to the impaired outflow owing to protein aggregates, silicon droplet debris, and damage to the outflow pathways due to the repeated trauma. And and in this cases, the patient can be referred to the glaucoma person for surgery or adequate management. Routine monitoring of IOP is thus essential after every procedure of intravitreal anti-VEGF. Ocular hemorrhage can happen in any case of injection. SCH is the most common, which is noted in 10% of injection. And it is very high in person who are receiving aspirin. Massive choroidal detachment, hemorrhage, subretinal hemorrhage, all things are not that much common. And increased risk of thromboembolic events after stopping anticoagulant therapy is high. So nowadays we are not insisting on stopping antiplatelets before injection. Adverse events following intravitreal anti-VEGF injection, some special diseases in consideration. In diabetic retinopathy and retinal vascular occlusion, there may be progression of TRD in cases where there is traction. So the fundus should be properly examined before posting for an injection, for even if it is for edema. Which all cases it will be high in suspect, it will be in cases more than 15 years of diabetes, or in patients who have received injection 13 days prior and uses of higher doses of anti-VEGF. And Gosser glaucoma have been reported in following use of bevacizumab as an adjunct to vitrectomy for PDR in highly proliferative diabetic retinopathy cases. And other thing in diabetic or CRV vascular occlusion patient, the repeated injection may cause decrease in the retrieval blood flow parameters, which leads to retinal arteriolar vasoconstriction and worsening of the macular ischemia. So people who are receiving a long course of anti-VEGF should undergo serial FFA just to document. Means if you are suspecting the macular ischemia, FFA should be done in such cases. And in age-related macular degeneration, so there are chances of RPE tear or rip. So in cases of PED or pre-existing RPE detachment or fibrovascular PED, in PED itself, when it is tall in nature, we have to do intravitreal anti-VEGF with caution. Here also we have to do the procedure slowly with slow pull out of the needle. In ROP also, there may be late recurrence of ROP and TRD can occur up to 35 weeks after initial regression with intravitreal bevacizumab. So, though the resolution of ROP happen, long-term follow-up of these patients till the periphery of the retina is vascularized is needed. And the surgeon should be ready for vitrectomy within 1 week of intravitreal injection of bevacizumab in eyes with ROP stage 4 and stage 5. And late recurrence of ROP can even after, so we should be very careful. And coming to brolucizumab, it is a recently approved single chain fragment variable. It has better control with less frequent injections. It was also beneficial for eyes that was non-responsive to other treatment. So high incidence of intraocular inflammation, particular retina vascular inflammation is there. About 10% of this inflammation are self-limited, but 30% of the eyes who is receiving this injection can develop visual dose due to retinal arterial events. So brolucizumab injection should always be done with caution. Phase 3 Merlin study, and brolucizumab 6 mg is compared with aflibercept 2 mg given every 4 weeks following the loading dose in patients with neovascular AMD. So in these cases, the rate of IOI following brolucizumab every week was 9.3%. So all clinical trials involving the brolucizumab was discontinued due to this side effect. What are the take-home messages? Inject only when indicated. Consent should be taken, explaining all the complications to the patient. Pre-injection slit lab examination is necessary to see the anterior segment status. Sterility has to be kept in the maintained in the theater. Injection technique has to be perfect. If needed, don't delay in to do IC paracentis. Proper guidance to the patient to be given. Warning symptoms to be explained. Follow-up has to be done just after 1 week. Thank you.